Hello and welcome to Level 3, Unit 304. This is the Person-Centred Care Unit. We're going to talk about what is person-centred care and we're going to compare it to another model in this session, in this set of slides. Okay, for your assignment, you do need to compare it to one other model, and I focus particularly on the medical model. If you decide to find another model that you want to use, that's fine in your own personal reading, but it's also fine just to use the medical model, which I focused on in these slides. Okay. So let's think, what is person-centred care? Maybe before I go on, you might just want to take a moment to jot down some ideas of what your knowledge is of person-centred care, what you might have heard or what you might have read. Those of you who are already working in a placement, you might already have seen some examples of person-centred care. So maybe just jot down some ideas, take a moment to think it before we move on. You might want to pause the slide if you want to just get some ideas down, or if not, we'll carry on. Okay. So it's a term that's used to refer to quite a few different principles. There is no single agreed definition like there is with some things. It's partly because it's a sort of a growing and ongoing and evolving sort of process. So you might see some people try for definitions, but they can be quite different. So it's really focusing on care around an individual rather than a group in that sense. That's the simplest way of looking at it. So if you work with people in a care home, instead of sort of treating them all the same, you look at each person individually, what are their needs, and you devise and provide your care in that way. So you might have three elderly ladies of the same age, same sort of problems, but they may all have very personal different issues. So you don't necessarily write them an identical care plan. So it will depend on the needs and circumstances of that individual and their preferences too. And this is where making sure that you find out about people's choices. That's a real strength of person-centered care. So some people might think some things are important, other people might think other things are important, and they might not want to address it. And you're really going to have to really flex to sort of meet what they want to do at that time. Okay. So as you can imagine, your care plan is an evolving thing and a changing thing, depending on whether people's needs change and how they feel about certain things. There might be something that they didn't want to do that after, discussing it for a while, a bit later on, they might say, okay, yeah, I'm willing to have a go at that. So don't assume that your care plan is a one-off thing that will stay with you and the person all the time they're in your care home. Do assume that you will be reviewing it regularly. And for some people, it could almost be daily, especially if they're new and maybe nobody's really sure about what their needs and wants are yet, and you may be taking time, so you may be adding to your care plan as you go along. So assume that your care plan is always a live document that has to have an ability to change. So don't do too much printing and things like that. Keep it where it can be flexible. Four main principles of person-centered care. You really need to sort of remember this. You may be questioned on it many a time during your job role, really. So if someone asks you to say, what are the principles of person-centered care? It is personalized. It is to that individual, as I've said. It's not about a group of people. It's about, every care plan is one-to-one. It's also coordinated. So you work things out, who's going to do what. You may have to bring in someone with special skills. but the service user knows who's going to deliver what to them. So very often they will be allocated a key worker whose job is it to sort of manage, their main conversations. Everybody's involved, but often someone takes a bit of a lead on it. And that's usually the person who's identified on reviewing their care plans with them. So they know that, and they know that if they want to make changes, they say, right, I'm going to sit down with Sue and say, I want to change my care plan. So I'll wait till she comes on shift this afternoon and I'll ask to see her. Care is also enabling, not disabling as well. We're always thinking to keep people as independent, and to give them as many skills as they want, within our gift, really. So it's an enabling process. So we don't remove people's skills by doing things for them or to them, okay? But we might need to do things with them to help them do things that maybe they can't completely do by themselves. So remember, it's important for you to think. The best way to think about it is that your care is done with someone rather than to someone. So maybe just keep that idea in your head. The final and the really important principle, again, something you need to be able to rattle these four principles off. You may get asked when your care home gets inspected, or when you go for a new job, those sorts of things. You need to be very confident about that. Is that the person is treated with dignity, compassion, and respect at all times. So whenever you're doing something with somebody, you're thinking about how much can I maintain the dignity? How much can I, make sure that people don't get embarrassed by what I'm doing? Now, sometimes because you will be doing very intimate things with people, it's hard not to do something that can be a bit embarrassing for you or for them, but you just need to do it in the most gracious way that you can. Make sure that if you're taking someone to the toilet, that they're covered up and they're not left with their bottom being shown to everybody, as much as possible. The doors are shut, privacy is maintained, those sorts of things. And also treating people with compassion, showing a bit of empathy for if someone elderly and they may be struggling to move, they can't move at a certain speed, be compassionate instead of sort of getting frustrated and annoyed that they can't keep up with you. And treating someone with respect. Think about the language you use when you speak to your service user. They are still your service user, they are a client of your services. Somewhere along the way, they are paying for your services, no matter how they do it. If it's private care, then they are paying. Even if it's like in the UK, we have quite a lot of services that are from the NHS. They have still paid by paying their taxes and things like that when they were weller and more able. So, a little bit of respect for that, and think about the language you use. Don't belittle people. Don't, don't sort of give them nicknames that maybe they haven't asked for. Check if you're allowed to use someone's first name. Somebody might not let you do it until you've built up a much stronger relationship. Don't just leap into it starting to call them, like a babyish name or a very familiar name, because they won't thank you for it. If I went into a care home and I really didn't know any of the staff, I would expect them to call me Mrs. George Putzer, and until they got to know me. And maybe then I would allow people to call me Sue, but maybe not everybody. And that's pretty normal. That's the way we operate in the world. So you need to think about this. Just because they've become your service user, you cannot take their dignity and respect away. They are an older person. They are often your senior in that respect. So you need to treat them in that way, and not suddenly treat them like one of your children, which does happen, I'm afraid. So it's something you need to be super careful of. Okay, now I said that I'm going to compare it to a model. You can find other models to compare it with if you've got the energy, but there is nothing wrong with using the medical model. It's the one that a lot of people will use when they're doing this assignment. So this is why I've decided just to focus on the medical model. And person-centered care is very different from the traditional care model, which was the medical model. And most long-term care was designed around the medical model, certainly historically, which sort of grew out of hospital treatment, really. So when people moved from hospitals maybe to care homes, there really wasn't a lot of difference. Care was driven by the diagnosis. Has this person got dementia? Has this person got a fractured hip? And tasks were identified around that diagnosis. And then certain individuals were asked to perform it. In the very traditional role model, staff really make the decisions about a person and they just do things to them. And it's quite hard for them to help people get independent. And there's minimal input from other providers, and there isn't a lot of personalisation. So if you're working on an orthopaedic ward where you've got 8 elderly ladies with hip fractures, you sort of, trust me, I've been there. You sort of see them as eight hip fractures that all need to, have their dressings checked, have their bottoms checked, be turned, you know, have a look at their skin state, whether because they've not been moving that well, and do their mobilization exercises. So it's quite easy to fall into the trap of sort of saying, okay, they've all got the same task to do, but that isn't necessarily so. One person might be very frightened, one person might be very comfortable and might be wanting to mobilize really, really quickly. One person might rather do it with their family, all these sorts of things. So, still, the care plans need to be personalised. One person might be suffering from more pain than another, and that could just depend on the type of fracture or type of surgery they've had or their own threshold of pain, and so that will be reviewed individually as well. So, I've done a little comparison here. The traditional medical model is provider centered, so in that sense it's like the hospital or the care home. It's based around how it works easy for you as the staff. It's founded on the principles of beneficence and authoritarianism. So it's like, we know more than you do, so we will make the decisions. It's very disease orientated. So it's like, again, I said, if someone's got a fractured hip, it's like, well, this is surgical procedure. What Let's focus on getting that wound cleaned and getting them out. Focuses on what's important to a physician or to your doctors, and their main driver is to the removal or reduction of illness and disease. Patient's perspective is usually ignored. They may ask questions, how you feeling and all that, but they may not, do much about it. And they may just say, oh, I'm in pain. Yes, well, you will be because, you've just had surgery. So they don't really take it into account. Someone might be suffering more pain than others. Their nerves might be more exposed than others, and their threshold of pain might be lower, or the type of surgery might have hurt them a bit more. And there is an expectation of compliance. You basically do what you're told, and there's something about the doctor's status as well. Well, I'm very knowledgeable and you're really not, so I'm telling you what you should do, and I don't really expect you to argue with me. And the aim is to improve outcomes for averages because they're looking at statistics across the ward. So they want, all of their 8 people with fractures to get better within 6 weeks or something like that. Very different from the patient-centered model or the person-centered model as it's become, because we try to drop some of that medical language, which is patient. So this is, person-centered has even moved on a little step from this slide, really. Founded on the principle of autonomy, which means Instead of being told what to do, the person, has is making their decisions, so it has to be discussed with them. And if they don't want to do it that way, well, they won't do it that way. So the care is very person orientated. So it's like, okay, what care do you need, Mrs. Jones? Is it different from what Mrs. Brown needs, even though you've got maybe the same injury or you may have had the same surgery? It focuses on outcomes that are important for patients. So for some people, they might be really worried about they want to get back to their jobs, they won't get back to work. And it's like, really, because I can't afford not to be at work because I can't pay the bills. The other one is that could be I'm a grandma and I'm a carer for my, daughter's children. And like how quick would I be able to get back to sort of lifting the children and managing them. So everyone's got different outcomes, and when you do the care plan, you need to consider things like that. Somebody, it might not be about walking, but it might be about caring for their, even older husband or wife or something like that. The patient's preferences, objectives, and values are taken into account. So, what's important for the patient or the person? And think about their values. You wouldn't make them do something they didn't want to do. Now, in the medical model, very often people's cultural needs can get a bit bypassed because to a doctor that's not a big issue really. The issue is to heal their illness and get them on their way. But you might sort of say, well, this isn't working for me because my cultural needs say, um, I can't have a male physiotherapist sort of dealing with such an intimate area. So I won't, I don't want to do the exercises with that physiotherapist. Now, in the medical model, they'd say, well, that means you don't get any exercise. But here, in the patient centered or the person centered, they'd be thinking, okay, yeah, right, well, we understand that. We need to make sure we get the right people to do it for you. It's just as an example. Um, in the person-centered model, the person and the doctor and the nurses and other people in their team share the decision making. So the decision isn't just made by the doctors. It's you say, well, actually, doctor, that won't work for me. My family can't manage that, or so they've got to come up with something else. And the idea is to prove the outcomes on that individual, and if they add to the greater statistic later, fine. But it's really about that person's outcome. What do they want to do? Get back to work, get back into being a grandparent, get back to being a carer, um, just get back to be able to do their garden at home, or get back to be able to do their housework and keep maintain their independence. Everyone's got a different goal. So, as I said, the medical model is very task orientated. You can use this to compare, really. The nurse in charge is responsible for all the patients on their ward or in their care home. Individual staff will get specific tasks. So you might find you've worked in a care home where in the morning there are certain sets of jobs to be done. If you're following the medical model, it's like, right, everyone's blood pressure's got to be taken at 10 o'clock, or everyone's medicines, two nurses will be identified to do the medicines, one person will be doing obs, another person will be getting people up to the toilet one after another. Everybody should be up for breakfast by 9:30. So I will allocate you and you to get the breakfast ready, you and you to toilet people, you and you to do the observations, that sort of thing. So it's not really about the people that might be connected with your care plan. It's like, there's one person doing everything. So especially in older people's care, there's lots of people doing different tasks. It's hard for the older person to know who to talk to about what, because they don't connect with their key worker. Now, appreciate the key worker is not on every day and not on every shift, but usually someone is allocated. If you're doing person-centered care, If the key worker's there, they will be allocated to their individual people. But if the key worker's not there, then somebody else will be allocated for the shift. So you would come in and say, "Hi, hello, Mrs. Jones. It's Sue here. Hi, how you doing? I'm going to be your key worker today. So if there's any issues and you want me for anything, um, and we might have to have a little look at your care plan later on, but I'll be in to get you up and get you washed and dressed in a bit, you know." And then you will probably do most of the jobs for them. So if they need their observations, you'll get them up, you'll do their observations, you'll take them to the toilet, wash them, dress them, and then take them to breakfast. And then somebody else will be doing that to the lady in the next room. So in that sense, you'll follow things through, so they know that this morning, if there's any issues, if they want any help, they can call, or if there's something that they feel is not working in their care plan, they can call Sue and discuss it. Obviously, most clients, if they really want to go to the toilet, they'll call anybody who's around. But generally, we try to do that, and I would be responsible for sort of checking on her regularly. Do you need the loo? Do you need anything else? And sort of popping in and out with them. So they know that someone has got their eye on them and they know who it is. Okay. So that's the big difference. So again, I've done another little comparison here. You can read it through. It's very much a synopsis of the sort of things I've just been saying to you in the last few slides. Follows a social model, follows a medical model. Most importantly, power is with the professionals in the medical model, but it's equally shared in person-centered care. Emphasis is on safe care that respects the person's rights. The medical model tends to be more concerned about protecting people from risk because you don't want their wound to get any worse or something like that. Okay, and it's fairly static, whereas person-centered care is much more working towards change, developing abilities, developing capacities. So you can use some of these slides for 1.1 when you're comparing it. Okay, so when you come back, this is where you look at your first couple of assignment bits. So how have care homes changed then? Thinking that as we've moved more and more from the medical model towards person-centered care, the care homes have to change as well. So the important thing is that they've eliminated this assembly line approach that I said, all right, it's 8:30, everybody has to be up, everybody has to go to the toilet, everybody has to have a wash, everybody has to be down at breakfast by 9:30, meds need to be given, observations need to be done, bum, 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 So that sort of assembly line process. So people really need to know. So Mrs. Jones doesn't like getting up early in the morning. She takes her breakfast a bit later. She'd rather have a shower after breakfast, as the case may be. She'd rather have a cup of tea before she starts getting washed and dressed. So the facilities need to try and accommodate. Now, I know that can be quite complicated where you've got a kitchen and 32 meals being done, but they need to find ways to do it. Most people do tend to get up and do tend, if you say breakfast is available from, 9:30 onwards, there might be someone though who really, really likes getting up early, and there's no real reason why you can't, provide a simpler breakfast and say, well, if you'd like to eat a little bit more later on. Some people might prefer just to have toast and tea early in the morning, and then join it for a cooked breakfast later, or not, and have a larger lunch and things like that. But it's really up to the care home to try to make those things work. The most important thing is about, instead of sitting in the office creating some care plans, you're actually sitting down creating a care plan with the individual. And they might want family and friends to be involved, to help sort of give views and to help to express things they might forget about. And you need to try and accommodate that as well. So that's another change. Where maybe in the early years we would sit and sort of have a look at what someone's problems were, and we would sit in the office and sort of, create a care plan and then say this is the person's care plan, and they may never actually see it. That is not acceptable nowadays. So the basic beliefs of person-centered planning is that the person's desired future is going to become the framework. So, what are they aiming for? What do they want to do? Do Somebody might want to get home and live independently. Someone might think, well, actually, I've learned from this that I do need help. So they might want to go home, but to work with you on the sort of services that need to be put in, maybe some domiciliary care to come in. Or they might actually say, well, you know what? I think I can't manage at home. And I might be wanting to look at a care placement for a long term, whatever. But it's what their desired outcomes are. The important part of this process is the dreams, desires, and preferences of the individual. Okay. Remember, especially if they're going to live with you for a long time, from then on, it's up to you to make sure that some of their dreams and desires still get achieved. And there is no excuse just because they're in a care home. Okay, you've still got to try and work out ways for them to do. This can be quite challenging for staff. Nobody said it was easy, but that's really what you're there about. Planning is beginning with the input from the individual, and they can bring in important people. They can say, well, actually, I want my daughter to be involved in this. She knows so much about me. I might forget some things because I've got a bit of dementia. The principles: person is always at the center. Family members and friends are also partners if the person wants it. If they don't, then they're not. The plan reflects what is important to the person now, so your immediate goals, and then think about some future goals. You also need to show what they can do at this moment and what support they will need to achieve those goals. Maybe a lot, maybe a little, maybe something they can do quickly. It might be a long term thing. The plan helps to build the person's place in the community. So it's about them either, returning to the community they know and love, or if they're moving into a new service, getting involved in that community and the community around. It's not just about the people they live with, it's about neighbours and people outside the local shops, things like that. It is ongoing. It is a listening and learning and further action process. Okay. And it's about trying to achieve what they want out of life. It's not just saying, well, this is all my care home can do. We don't have that service here. It's about, okay, how can we get it here? Or how can we get you to the service? Okay. So if you don't have an in-house hairdresser, can we find a mobile hairdresser to come in? Yes, you can usually. And they will probably quite happy come in and come to a care home if a few people are interested. Or if not, can I get Mrs. Jones to the local hairdressers? It's only 100 yards down the road. So, can we do that instead? Is that something she sees as more of an outing rather than just being inside the care home all the time? Or isn't it something that bothers her and she thinks, yeah, a mobile hairdresser would be quite handy. I don't really like going to hairdressers. So, yeah, but I'd like to have my hair done now and then. So, choices are different for different people. The planning process is very similar to most planning processes that we have talked about before. The top point is gathering information, identifying what those wishes, feelings, and goals are. So, thinking about some short terms, thinking about some long terms. The second one is exploring options. What can we do to achieve this? Doing some risk assessment, what will be a problem, but also identifying what might be the benefits. And then after that risk assessment, you put a plan together with the individual. What can be provided and how will we do it? And remember, with a risk assessment, you don't always completely get rid of the risk, but you try and reduce it as much as possible. So, what can we do to avoid that? The next step is delivering that care plan. in line with the way the person wants it done, okay, and they want it delivered. And then finally, monitoring and reviewing. So getting some feedback, making some changes where you need to. So it's a standard planning process. It's almost the same as policy planning process we've looked at elsewhere. Planning processes are planning processes. At the center, at the heart of it all, is the relationship between you, the carer, and that individual. And really, the better the relationship, the better a care plan you can probably put together. Three main things to think about, all about conversations, really, because person centered is all about your conversations, all about your interactions. So, what skills do you need to have? You need to be able to develop conversation to engage with people in the first place, to get them to trust you, to get them to work with you. Then you need to talk about conversations. How are you going to enable and support people? So, how are you going to develop the skills to support people? There may be, different little skills that you need to do in different some techniques in supporting people depending on what it is. Um, and then conversations with people about managing someone who's got very complex needs and who have significant risks, and how you're going to do that. And again, you might need some extra training for that. Very often people do risk assessment and working with complex needs. Usually, a lot of people, level 3 students, might do some short courses after that. Or if you're working, say, in a specific unit where people with learning disabilities, autism, say, you might want to do something on autism or something on challenging behaviour, something on complex needs. So it's about developing your skills. That these are the conversations you've got to have with yourself, really, about what do I need to do, and with your seniors. Do I have the skills? How can I develop those skills? You need to ask yourself, take a time to think about this. How do you ask people what they want in a way that invites them to share? Think about how you might go about that without shutting them down. So, how do you ask them nice and openly and encouragingly? How do you encourage and support people to get the future that they want? So, what skills do I need to do that? How do you help people to find their voice? So, how can you act as an advocate for that person and get them to speak up when they're not happy about things? It might be, at a clients group, often care homes might have clients meetings every month or something where people talk about raise issues they're not happy about or they'd like to see some changes. Some people might be better at speaking up in those sort of meetings than others. How do you help your client to do that, your service user? Um, think about those sort of things because those are the skills that you will need. Key points to make in a person-centered plan. This is really just a summary of what we've been discussing. Start with the person. Find out what they want, what support they need, what capacity do they already have, who already helps meet some of these needs. Will there be somebody at home if they're going home to it who can help? And what support can you provide? There are lots of tools actually to help you care plan. So a plan really needs to have an action and they need to have goals. This is a possible tool that I've seen used a lot. It's known as a one-page profile. You do a much more detailed plan that sits in someone's file, but these one-page profiles are available, often at the front of someone's, if it's paper records or electronic records, they might sit at the front of the record as well. And as you can see, it's got sort of a little picture, some special things about me, what people admire or are interested about me, what is important to me, where this is all from the service user, and how best to support me. So You know, I can't manage my telephone. You might have to help me dial the numbers and then hand it over to me. I can't. I can go to the toilet, but I can't wipe my bottom very well, so you might have to help me with that. So these little things that you can put in there. It's a one-page profile. It's really great for new staff and agency staff who's coming in to work with someone. And they don't know them very well, so someone's just joined. It's a great one-page profile, and it helps the service user. They can look over it as well, go, I want to change that now. So very popular, the one-page profile. I've seen it used a lot. As I said, it doesn't replace the detailed care plan with lots of goals and actions, but it is a good thing to work with. You can actually get an e-learning course in one-page profiles. I have put a link there with SKI, Social Care Institute for Excellence, one-page profiles. So if you click on that, they used to actually do a free course, which you can do if you want to do. Quite good, actually. It take you a couple of hours, but it's something very nice, really. But they certainly tell you a lot more. If you don't want to do the course, you can certainly go onto their website and just find out more about it. Some people might be non-verbal or might not like a lot of written stuff. They like to create their goals in a more visual way. This is quite a classic one. So it starts at the beginning when you get together, where it starts with the sign in, and these are the people who are involved. It can add new people to that signing thing. As you can see, the arrow starts with now. What sort of things do I want to do? What are my strengths? What are my first steps planned? A review date. What comes in the arrowhead? What happened in that review? This is like a year. And then in the big balloon is what, positives and possible. So coming out of the review date, you might sort of identify things that you really want to do in a year's time. So you can jot some of those down, or you can leave room for things that did happen. The star at the end is when you've achieved a lot of things, and you can fill that in as you do things. Now, a lot of people, they get involved in the drawing of it, or you can actually get this as a template as well. And I've known people have it as like a poster on their wall, and it gets completed as things go along. It's quite nice. There are other really nice templates like this that you can download. They're not that expensive actually, and you can turn them into poster size things, so blow them up a bit if you've got the paper. And you can colour it in with them, and like this is quite a tidy one. Some people like to draw their own, but as I said, there's loads and loads of templates on. You can Google them basically, care planning templates. And a lot of people like to have this so they can just glance at it visually. So they're not having to look at a detailed care plan. Maybe they've got a bit of dementia, maybe got some learning disabilities where they find it a bit challenging to do all the reading. This lovely coloured one with some nice pictures and some nice events on it, really, some people really love. So that's something you can get for. The terms goals get used quite a lot. What we're talking about here is desired outcomes. So, what do people want to happen? What do people want to achieve? Okay, and it's personal. So they may want to achieve something that you don't even think about. Okay, because you're not in their head. So really, one of the things is if there is going to be an obstacle, what you need to do is sit down together and think about how can we resolve this obstacle? How can they remove it or make it smaller? So that's what you're looking at, and that's part of your risk assessment. Here's a little example. You might want to have a little think about this. We got Maria. She'd like to take the train by herself to visit her family. She's a young woman with learning disabilities, mild learning disabilities. She can do quite a few things for herself, but she hasn't really travelled that much on her own yet. She needs $350 because that's how much the train fare is. She needs to have a cell phone or a mobile phone to call in case she needs help or, she gets confused. What does she need to learn? So I'm going to ask you to pause here and maybe jot down some ideas. Think of the things she would need to learn if she's never done this journey on her own before. Take a moment to do this, and then when you're ready, move on and I'll just talk you through it. So just click a pause. Think about, just jot down some ideas. What does Maria need to learn? Things she needs to learn are how to find and schedule a train ride, how to purchase the tickets, what sort of things to pack. Is she going for an overnight? Is she going for a few days? Is she going for a week? What does she need to pack? What's the weather like? Is it chilly? Is where her parents live colder than here? Or, warmer than here, etc. How would she find her seat on the train? Does she have a reserved seat? Or is it just a sit anywhere train, so it doesn't matter? She needs to know that. What sort of personal safety skills does she need to know? How does she need to look after things? How does she need to look after her money? What's the best thing to do? What she has with her, what sort of valuables she has with her, what to do if a stranger approaches it. She needs some sort of plan for all these things. It might be that she sits in the you work out with her which is the carriage that has the guard in it, and she sits there. Or it might be that she's that nervous that you want to alert the guard, or somebody might see her onto the train and then just mention it to the guard. But otherwise, what skills has she got to do? Does she use her mobile phone? Does she pull the emergency cord? When does she do what? What is the emergency procedures? To achieve these goals, you can support her to learn the skills needed by doing little bits at a time. It might taking her on short train journeys and practicing some of these things with her. And then you can help her to plan and save up the money she needs. Where does she get her money from? Does she get pocket money? Does she get benefits? Can she put a bit aside? So these are the things that you think about with her. But to do it, you can't expect her to do all this at once. So you're going to have to learn these things bit by bit. So you'll show her how to do the train ride, purchase tickets. She might be okay online. She might be okay using her phone. It might be the social skills that she's not so good at. And then you can take her out on short train journeys and sort of talk her through some of the things that she needs to do, and then let her do it on her own. Maybe you sitting along behind, but letting her sit on her own, and there's lots of ways to do it. Goals should be dynamic. They do change. Don't assume that everything, once it's finished, that's that person's life over. They keep going on and they keep changing. And once they've achieved one goal, they want to create another one, like we all do. Okay. So they're no different to you or I. They want to, what am I going to do next week? What am I going to do next year? What am I going to do in 10 years' time? If you find your person is frequently refusing to work on the goals in the care plan, maybe you need to revisit the process, because maybe the goals that you've set are not appropriate anymore for some reason. So you might need to talk to them about why don't you want to do it? Are there is there a goal that you would rather do that's more important to you? Yeah, that's generally the way it is. Maybe something in their mood has changed or in their mind has changed. Okay, that's the basic really about the care planning process. I've added a little piece of reading for you for the Healthcare Foundation, more detail about the planning process. So I would read it. It's quite a nice summary. So read and review that as well, and that will help you probably with part of task one. Okay. And in the next set, we're going to look at the second part of task 1. We're going to think about attributes and values, and some of the skills that you require. Okay, so that's it for now. Okay, thank you very much. I'll see you in the next session.